All right, it is 2:45 and we'll get started. I know some other folks will trickle in. Welcome everyone. So my name is Jillian Grant. I use she, her pronouns. If you feel comfortable adding your pronouns to your chat box, please feel free to do so. Okay, cool. And so, yeah. Welcome. This is the breaking down organizational silos section of the schedule. I'm the moderator for this session, and we have Peggy, I believe you're in here still, who's providing tech support. Her box says COD breakout room 2. If you have any issues, please feel free to message her directly. Hey, there she is. Thanks for waving. Yeah, welcome. And we have 2 presentations during this session. Each presentation is going to be 20 minutes with an additional 10 minutes for Q&A. So it should take up about 30 minutes in a time slot. We will have 5 minutes in between each session for you all to stand up, take a little screen break, walk around, get some sunshine, and everything like that. I am really excited to be a part of this session and hear about these presentations for today. And our first presentation is going to be with Claire Peters and Varsha Kumar. And the title of theirs is Making Community Health Implementation Plans More Accessible and Robust to Community Stakeholders. Chip chats, which I love. Great. And like CC, chip chats. All right, so I will set my timer for 20 minutes and I'll let you guys know when you have a couple minutes left, and I will let you all take it away.
Awesome. Thank you so much, Jillian. Can everyone hear me okay? Great. Let me just get settled in. All right. As Jillian mentioned, we're here today to talk to you about community health implementation plans at Children's Hospital Colorado and how we're working to make our data tied to them more accessible and robust for our community stakeholders. And we want to talk to you about our chip chats. My name's Claire Peters. I am the interim manager of data analytics within our division of community health and advocacy at Children's Hospital Colorado. I joined Children's in 2016 in the data analytics space, and my background is in analytics and public health with a master's in public health at the Colorado School of Public Health. And I'm joined by my colleague, Varsha Kumar, who can introduce herself now.
Thanks, Claire. Hi, everyone, and thanks for being here. My name is Varsha Kumar, and I also have my MPH from the Colorado School of Public Health, which I got in May of 2021 before working at Children's Hospital Colorado, which I've been working at for a month and a half. I worked at the Colorado Department of Public Health and Environment. My position is an EPIC data analyst development professional in the Analytics Resource Center, and I also work closely with the population health team.
Great. All right, for today's objectives, we really wanted to talk about 3 things. First, we wanted to talk to you all about how tools such as REDCap can be leveraged to break down organizational silos and help to centralize and standardize the way we gather data for our community health initiatives. The second objective is really to demonstrate how these dashboards can not only visualize information, but make seemingly separate bodies of work come together and create better access to those data that is gathered to help showcase what we're doing in the community. And third, we want to describe and discuss how we can address some of the barriers and challenges that we face and you might face during this process. First, let's get a little bit of background for those who aren't already familiar on the community health needs assessment process and implementation plans. We want to talk about what they are, why we do them at hospitals, and what's new for ours at Children's Hospital Colorado. So a community health needs assessment, or CHNA, is a process that hospitals go through to understand the health needs of their communities. It's a standardized or systematic process in which we gather data from the community, as well as secondary data sources to really delve into what are those needs in our surrounding communities. The CHIP, or the Community Health Implementation Plan, is really the response to the CHNA. So how are we going to work to address those needs that we identify in our CHNA? Why we do this? Hospitals that are not-for-profit do this as part of their mission to improve the health and well-being of patients, families, and their surrounding communities, and to ensure that we are compliant with federal requirements to assess and respond to community health needs. Each time we do this work, our CHNA process really evolves and expands. And what's new about our most recent CHNA is that we're really thinking about how, with our expanded roles in the CHNA process and with the expanded teams that are participating in our CHNA and our implementation plans, we're really needing to think about how we can better capture the measures that we work in or the work that we gather. So in previous CHNAs and implementation plans, we've really been a one department shop. We've had a community health department with about 6 teams, and those 6 teams really do all of our community health initiatives. Now we've really expanded into the entire division of the Community Health and Advocacy Division, where roughly around 15 teams have separate initiatives in our community health work. And right now we're capturing roughly 100 different measures. And so with this expanded scope, we're really trying to find a way to better approach the work that we do. First, we needed to improve how we capture our measures. Second, we needed to think about how we engage this larger group of team members to connect to their work and to each other, and how those bodies of work roll up into our broader goals. How we decided to do this was through our CHIP dashboard and CHIP chats, which Varsha will be diving into a little bit later in the presentation. And from these approaches, we really found that we are making connections between teams more effectively by capturing and more standardizing the data that we have in a centralized way. And we're creating more visibility and access to the data. Through this process, we are also helping to promote some accountability to report measures among team members to ensure that their work is showcased in the dashboards. So let's get into a little bit further. As background, in a recent CHNA for our hospital on Anschutz campus in Aurora, Colorado, as well as Colorado Springs, we conducted our more recent CHNA and identified one priority area, which was mental health. This was the first time that we have focused on one area, but really what we're doing is diving in much further into this need in particular. Previous needs assessments expanded into 6 areas. And so this is a much deeper dive into one priority area for this iteration of a needs assessment. Moving on to the CHIP, or the response to those needs assessments, we have 4 key goals to work to address mental health in our communities. And I'll outline the goals on the left-hand side. The strategies on the right-hand side really are examples of the initiatives, but I'll focus more on what the measures are associated with the goals. So for the first goal, we're working to improve mental health awareness and reduce the risk of suicide. In reference to our measures in our dashboard, an example of a measure that we're capturing in this space is the number of provider trainings that we conduct for suicide risk screening. Under goal 2, we're working on improving systems of care and access to mental health services. A lot of this work is tied to our policy and advocacy work. And an example of a measure for this would be the number of amendments secured on legislation and/or regulations impacting children's mental health. For goal 3, we're thinking about mental health and how there are certain things we can do to promote protective factors and reduce risk factors for mental health conditions. And this is really looking into the social determinants of health space and the community health initiatives that span beyond strictly or directly mental health services. A measure in this area that we're capturing as an example is looking at the number of patients and percent of patients that we're screening for social needs, and the percent of those who have received a referral or navigation assistance in response to that need. Lastly, in goal 4, we are focusing on promoting community voices and engagement to inform, advise, shape our mental health strategies and systems of care. This goal really is, I see it as sort of a feedback loop into the other goals. So when we're thinking about addressing mental health needs in the community, we need to continuously hear from the community and ensure that the approaches that we're taking are responsive to our community members. And so at various levels, we are engaging, participating, or leading initiatives in the community as it relates to mental health. And this all works to feed and inform the work in goals 1 through 3. Really in goal 4, in terms of measures, we have a lot of milestones. So an example might be getting feedback from a family advisory council that we use to inform or apply to a policy or program tied to mental health. Thinking about how the CHIP implementation plan and how we've drafted that work then feeds into a dashboard. This is the way that we structure our implementation plan. We have goals. Within those goals, we have specific strategies and tactics. And then within those, we have measures. And so this is really helpful for us as we think about building out a tool that can help capture goals that would then roll up to measures that would then roll up to a goal. I'll pass it over to Varsha to talk about REDCap and dashboards.
Thanks, Claire. So Claire just gave an intro on what the CHNA and CHIP are, and now I'll spend the next few minutes talking about centralizing, visualizing, and sharing data for feedback. Next slide, please. So why use REDCap? First, what is REDCap? REDCap stands for Research Electronic Data Capture, and it's a HIPAA compliant application designed for the collection of data in research studies. Before I continue, I just want to give the disclaimer that while we use REDCap at Children's for the CHIP data, this is not the only survey tool out there. Other options that you may be familiar with include Qualtrics or SurveyMonkey. So one of the key takeaways is what we did previously and what we do now. So previously, manual data capture lacked standardization. Now there's one process for capturing data in REDCap. Previously, programs would change measures and it could be difficult to keep track of those changes. In REDCap, it's easy to update the measures in the tool. Just make sure to document changes, so when looking back, you understand why things may be different from when you started. And finally, previously, it was difficult to centralize reporting due to the different reporting styles in each program. For example, some programs may choose to fill out Excel spreadsheets, some may make tables in other programs, etc. Data is from different scattered locations, so this might involve some back and forth conversations in order to figure out what's going on. In REDCap, it's one reporting method that feeds into a centralized visual. So REDCap keeps track of survey responses, and at the end, you can download a spreadsheet that neatly has all the data you've collected, which can then be fed into a visualization software such as Tableau or PowerBi. REDCap limits the potential back and forth because everyone is answering the same questions that you built out. Next slide, please. So before you build out a REDCap survey, there's a few things that you want to do. First, connect with your programs or your points of contact for all your measures to go through the reporting process and explain what you need from them. Second, categorize measures as quantitative or qualitative. This can help with visualization once data has been collected because quantitative and qualitative data will be reported or visualized differently. Next, confirm that you have what you need with data validation techniques to reduce user error. Make sure your survey questions will ensure responses that give you the data you need. Have team members go over the survey questions to make sure that they're easy to understand and will not be misinterpreted. For example, do things like make sure that if you want a date, then only a date option is available. Lastly, check your survey output with demo data to see if it will be easy to manipulate and analyze. So have someone on your team answer the survey questions as if they were an actual survey respondent. Check if the data you received can be manipulated and analyzed in the way you want it to be. And if there are any errors or problems with the data, you can adjust questions as needed before building out the survey. Next slide, please. So a few tips for creating your REDCap survey. The first one is include a point of contact in case there are data questions, for example, if a response doesn't make sense. Second, make sure your contact info is readily available in case respondents have questions about the survey. Include a field where respondents can put milestones or something they're proud of. This can increase engagement with the survey and the program. But also make sure your survey is flexible and customizable. These are all suggestions, but you know your survey and the kinds of things that should be included in it. Next slide, please. So this is a screenshot from a page of the dashboard, of the CHIP dashboard, that has measures that correspond with goal 1 that Claire spoke about earlier. So a few features are that you can use filters to go between different campuses or reporting periods. In this case, You can also track data over time to show change and impact. One suggestion is to use different colors and visuals, make sure there's a cohesive look, and you can find out from the marketing department what colors you should use. Another piece of advice is don't necessarily stick to the same bar graphs and pie charts that are normally used. There are lots of interesting visuals that grab attention better, like tree maps or bubble charts. In general, people will be more interested in and engaged with something that's visually appealing. Finally, you can look at Tableau dashboards on tableau.com for ideas, and Power BI probably has something similar. Next slide, please. So now we're going to talk about chip chats, which is a name we gave the discussions that we have with programs about the dashboard and the project. And it's really a means for getting feedback. Next slide, please. So there's a few things you want to do when it comes to getting feedback from stakeholders. You want to check in with your stakeholders after the first round of data collection. This not only helps with answering or asking questions that you may have, but increasing the stakeholders' engagement in the process as a whole. Another thing is to present the dashboard, even if it's not ready, to your stakeholders so they can see what their data is being used for. It's always tempting to wait until something is perfect to get feedback on it, but it's best to get feedback in multiple stages, even early on, so you can make sure that the dashboard you're making has what the stakeholders want and looks right, and you're going in the right direction. This way, you don't progress too far on a dashboard only to have to start over. And finally, and maybe most importantly, be patient. Visualizing data and creating dashboards takes time, and it's an iterative process. Your first attempt will very rarely be the version you end up publishing or disseminating. Your stakeholders may not be completely familiar with how to use the dashboard, and they may need additional time to look over it. Next slide, please. So often when asking for feedback, it's helpful to have guiding questions for stakeholders so that they know the scope of the feedback you're seeking. It's easier than giving just generalized feedback. So on the slide are a few examples of questions that are broad enough that they can be taken as is and asked to stakeholders. So the first question is, was the dashboard easy to use to find the information you needed? Another question is there anything in the dashboard that you found difficult to understand? Third, were there any visuals or information that you felt were missing from the dashboard? Finally, how do you feel about the current layout of the dashboard? This is also a great time to ask questions about specific parts of the dashboard for visuals or layouts that you're unsure about and for which you want to get stakeholders' opinions. Be sure to include questions on anything that you want to know more about and get feedback on. And now I'll hand it back over to Claire to talk about what's next.
Thanks, Varsha. Now that we've built the dashboard, we're making improvements to the REDCap tool as well as the dashboard based on the feedback that we've received. We're also continuously finding ways to showcase the dashboard to raise awareness of the work that we do across our health system, as well as among our community partners. Through this process, we're ensuring that the dashboard is accessible, relevant, and usable to the team members and community partners doing the work. We're really excited to be in this phase of sharing the dashboard now that it's published and gathering this feedback to make this continuous improvement and make sure that folks have access to the great work that they're doing. And with that, we can enter into questions.
Thanks, Claire and Varsha. What questions do folks have? I can start with a question, maybe to warm folks up. I'm curious, you just shared about some stakeholder feedback, and if you have anything to share with us about what you've learned and what changes that has led to for you all.
Yeah, so we had our first presentation to our division last month, and we've gotten some feedback from folks that I think are pretty dorky with dashboards, which is fun. because we're nerds about it too. And so we have some resources that we'll be able to dive into further, and they've given us some tips and tricks that might be helpful to better ensure that the information and the visualizations are accessible to a broader population. We're waiting to hear back a little bit more from folks about how their own data is visualized, and something that we didn't call out in the presentation, but that we want to get feedback from folks on is the fact that we in the dashboard have a select number that we have displayed under each goal. We're not showing all 30 for, you know, goal 1 and goal 2 and so on. And so we used our discretion, but we really want to hear from our partners about what's most meaningful to them. And so I think in the next iteration of feedback, we'll get a little bit more pointed in our questions to see if what we're showcasing is what's most meaningful to them, since there are so many measures.
Cool. The question in the chat, how do you identify and recruit, or Judith, do you want to get off mute and read that question, or would you like me to read it for you?
I really don't mind which, but certainly in this space, it is hard to identify and recruit stakeholders who can give us frank and candid feedback on the materials we're trying to share. And we do tend to have the same go-tos over and over, and I worry that we overburden some community stakeholders. Did you face it?
I think that's a great point. With the dashboard we have so far, we're, at least in this phase, really working with the people who are entering the data to make sure that we're representing it in a way that they can then share with other audiences in a meaningful and accurate way. So we haven't yet gotten to the phase of them then sharing it with their external community partners. So it's really, how can we showcase it to the audience, the folks doing the work themselves, so that they can share it within our health system. And then we hope to get to a phase where we're using this dashboard that can then go to community providers to showcase, or community stakeholders to then show the work that we're doing. I think the question about overburdening is a really good one. I think people look at dashboards for different reasons and have different starting places in terms of their data literacy, data comfort, and that sort of thing. And so what I always like to keep in mind is that there's multiple ways to give feedback, and that everyone looks at data in a different way. And so what I try to do is really see where we can help tell the story in a way that people can get excited about what they're looking at in the dashboard. And so I think about the questions that I bring to those conversations, and I do my best to think about my audience before kind of going into those conversations, to ensure that I'm not asking really technical questions to an audience that's really wanting to tell a story that you know, doesn't involve filters and action items and things like that, like Tableau can display. So being responsive to where I think folks are with their data literacy levels and comfort is one of the things that I think about. Is there anything, Varsha, you would add to that?
I really think you covered it.
Great. There was a question about, in the chat I see, about RedCap versus other platforms. I think that's a great question. I think we could have used a couple other platforms that we have. We have data in the dashboard that has patient information in it. And so as a way to protect that information, we use a HIPAA compliant database, which is RedCap or for us. And so that's the reason why we chose RedCap, but it certainly isn't the only tool that one can use. We were just thinking about making sure, whether or not it's patient data, that we had a platform that was secure enough.
Another thing is that RedCap can be used online and offline, as well as it can export data to more statistical analysis softwares than something like Qualtrics can.
That's a great point. We've also been able to make it a data source in Tableau, meaning we don't have to download the data and then upload it into Tableau. It updates as folks enter their information. So that's a helpful way that the information is more automatically updated.
Any other questions from folks?
Ooh, Julian, great question. Working at a hospital, our Tableau server right now is not, because majority of our dashboards do have patient information in them. From a security standpoint, we are not able to make them publicly available. This is something I'm working on. I would like to be able to have a version of that without, impacting the risk of doing that with other dashboards on Tableau. I'm not sure exactly how to go about that yet, but that's something that I would like to pursue, because in an ideal world, we would have this information publicly available on our website so that community partners could see it directly, rather than having us needing to present it to them on our computer and that sort of thing. So that is a barrier that we face right now, but is something that I'd like to work on. Challenges. I don't know. I think we've had really cooperative participants in the process. I would say with goal 4 and our milestones, we would really like to showcase that work in a meaningful way. But it's less conducive on a dashboard to kind of provide descriptive data or descriptive information about something that happened for a given program. So we're trying to get feedback from folks about that area in particular. Goal 4 is also one where we're looking at things that like number of bills tracked, a lot of work that our policy and advocacy folks do. And we just want to elevate what it really means to track, legislation and monitor it and advocate for certain things. And so some measures are more conducive to easily visualizing in a pie chart, like in a chart or a graph or trend lined in Tableau. And then there's other measures that, while meaningful, are a little bit harder to visualize and kind of draw that impact a little bit more. So I would say trying to visualize some of our measures to really demonstrate what it means and the impact. And then goal 4, thinking about where those milestones can be called out in a meaningful way for folks. Something else that Varsha has thought of that I think would be really cool is to think about it across all of our initiatives, how we can estimate the number of lives impacted and just have that sort of as the leading number on each of our dashboards, so that we know across all of these initiatives, like how many lives have we touched or impacted as a result of these programs.
And kind of piggybacking off what Claire said, a lot of our data is currently in a tabular format, which, while valuable, is not the most visually appealing. And we have a lot of data that's text-based. So a challenge there is kind of figuring out how to visualize it without just putting like lists on our dashboard.
Awesome. Thanks, Claire and Varsha. Okay, we have time for this one last question.
Can you talk about how some of the unique data visualizations ideas have been received? I would say they've been well received so far. We're actually trying to get more feedback from folks, but I think so far, we're, with the help of Varsha's expertise, we're trying to keep the tool pretty simple. And I think you probably saw that the filters there's only 2 options for filtering. Like if you're thinking about a broad audience using a dashboard, you don't really want to make it so complicated that they get lost in the filters and that sort of thing. So we're really starting simple. And like Varsha was saying, just trying to get a little creative with unique, more creative ways to display the data, except besides bar charts and that sort of thing. So we're asking for more critical feedback, I think, so that we can continue to grow.
Great. Did you want to add something, Varsha?
Yeah, I just wanted to add that the word unique actually also depends on the person's perspective. Like before I was familiar with Tableau, I didn't really know about tree maps, which basically show the same information as a bar graph, but they're visualized by size of squares rather than bars. So kind of depends on somebody's comfort and kind of knowledge of the different vizzes that are out there.
Awesome. Thank you so much. With that, we'll take a 5-minute break. Please stretch, stand up, get your eyes on the sunshine outside. We'll come back here around 3:21 and we'll have our second session. All right, welcome back, everyone. Hope you had a nice little break. Our second presentation is titled Reimagining the Collection of the Member Voice, a health plan's approach to cross-departmental partnership and engagement around surveying Health First Colorado member experience. Our presenters are Lauren and Sarah, and I'm going to set my timer for 20 minutes. I will let you guys know when you have about 2 minutes left, okay?
Thank you.
Yep.
Okay, well, we can go ahead and start. Hi, everyone. My name is Lauren Ratliff, and this is my colleague, Sarah Thomas. We're program managers within the quality department at Colorado Access, and we are here to discuss the reimagination of collecting Medicaid member voices. We use cross-departmental partnership and engagement to do this. Our objectives today include the following. We hope to assist with formulating some innovative and equitable survey collection methods in hopes to identify some new perspectives from the community that you serve. We hope to present a unique mixed methods approach to data analysis, one that prioritizes actionable results. Lastly, we hope to build skills around recognizing and assembling stakeholders and partners to enhance survey design, implementation, and the creation of actionable interventions. So let's start with the basics. Who is Colorado Access? We are a nonprofit health plan that coordinates healthcare for Health First Colorado members, which is Colorado's Medicaid program for regions 3 and 5. Sarah and I are part of the quality improvement team. So our purpose is to kind of ensure that our members receive access to high quality care and make sure that the care that they receive is received in an appropriate, comprehensive, coordinated way that meets or exceeds community standards. So what we mean by that is that we are focused on the member experience. It's crucial to understand member experience in order to reduce barriers to accessing care and to meet members' needs in ways that work best for them. We have the most diverse population in the state for a health plan. For instance, in Arapahoe County, there's 160 different languages spoken. Diverse identities need different things and have different experiences. So it's important to understand what those experiences and what those needs are. Understanding member experience is not new. Historically, this is most often done across the US with validated patient experience surveys, like the CAP survey. It's common for states to require the administration of these types of surveys. For instance, Colorado historically runs the CAPS health plan survey. And I think a good question to ask here is, if there are research-backed, validated surveys, then why do we need to reimagine the collection of this type of data? Well, we have seen pretty low response rates for the CAPS survey in recent years. This could be attributed to a variety of factors. The survey is pretty lengthy. It It also requires the executive functioning skills to receive a survey in the mail, proceed to fill it out by hand, mail it back, or do it over the phone or online if you're one of the participants selected. So in other words, it doesn't guarantee that it will capture an accessible audience. And the CAP survey does not allow for a qualitative survey component. And you folks know that there's a ton of benefits to qualitative data. Survey data can also be skewed in surveys like this to groups of the population who most often fill out these types of surveys. Lastly, I want to mention that there's a low reward for respondents. There's often not much incentive behind these surveys, and typically they don't connect members to resources they may need, resources often known about from their survey responses themselves. Members can't really see how their data can turn into action or why their voice matters with mailed surveys. So we believe that the reimagination of collecting member voice involves several pillars. We knew that we wanted to collect member voice through a survey, but we needed to know the right people to engage with to do this. This brings me to the first pillar of inclusion. We needed members themselves, as they are the experts in their own experience. We did this through the Member Advisory Council, which is a council comprised of Colorado Access members. They meet once a month. They give us feedback. They help us workshop survey questions. They approve the final survey. They give us excellent, honest feedback and are compensated for their time. We also utilize internal focus groups that hosted a variety of teams within COA. They participated in survey development such as care management, member affairs, diversity, equity, and inclusion team, health strategy teams, and of course, our partners, customer service. We made sure to offer multiple ways for team members to give us feedback. Some people are more comfortable talking through their feedback. Others may prefer to write that feedback out or give it anonymously through something like an exit survey. And a huge theme for us in the development of this new survey process was establishing trust with our partners. You all may have heard this before, but inclusion and trust, they take a lot of time to build, but once you have a solid foundation of it, work happens more quickly, and I find the value of that work to be high. We analyzed the survey using a mixed methods approach, so we used both qualitative data from the survey itself and then existing quantitative data. My last point I want to make is around data sharing. I want to note that it's important to close the loop and come back to your partners to give updates on the process, present results, encourage participation in actually designing the improvement opportunities based on results. It just helps to ensure that partners' voices are valued and shows them how much we appreciate the partnership. I also think this can help dismantle data silos within organizations themselves. So, what exactly is the member survey? We partner with customer service to administer a member survey 2 times a year. We have kind of realized that customer service is an untapped resource within Colorado Access. They talk to members every single day, and they get anecdotal data about member experience constantly, but they're not often involved in decision-making on how we better understand member voice and how we make members' experience better. So we have tried to work really hard to make sure that the customer service knows that they have a partner within the organization, and we've tried to give them a platform and hope that it empowers them to share their expertise about this topic. Customer service will ask members a short survey during calls when members are already calling for help. And then the quality team, we do the analysis of the survey, share the data, monitor the process, and create the improvement opportunities from that. As noted on the last slide, survey questions are developed from a variety of teams and sources. So to reiterate, this survey's purpose was to gather real-time feedback from members to better understand their experience and actually to take action from that feedback. Not enough surveys are geared toward action, in my opinion. Doing this survey a couple times a year has allowed us to, identify some trends in member barriers. It also lets us connect members to resources in real time, and it aims to increase, members' trust with the health plan. So to review the survey process, a member will call into customer service. The customer service representative will help them with whatever they're calling about first and foremost, and then asks if they want to answer 2 to 3 questions about their experience, and members will verbally respond, and the customer service rep records the responses in an online form. A survey iteration is considered complete once we hit 500 surveys. We do understand that these results could be biased since, one, we're hearing from members that are already experiencing an issue and members that are able to talk on the phone and respond to questions. Our intention here is just to capture an accessible audience and get data where we can. We know the system isn't perfect, but we think of it as one more stream of communication around member experience. This method has also allowed us to connect members with resources that may not have otherwise known about without being asked, without asking the members to reflect on their healthcare experience. So that's been really useful. And then with that, I think I'll turn it to Sarah.
Thanks, Lauren. So survey questions. We approached the survey with the goal that questions should be streamlined and efficient, and this can be really tough to do. Within public health, we often want all of the information when we want to ask all of the questions, but it's really important to respect both our members and customer service staff time. And so the survey was limited to 2 main questions, both quantitative and qualitative. Question 1 was quantitative and stated, have you had trouble with scheduling an appointment in the past 6 months at any of the doctor's offices you have gone to, with yes or no? And then if the member answered yes, we integrated a qualitative component to ask, what was the difficulty you experienced? So access issues have been a big area of focus within our organization. And so we just felt this question spoke towards the heart of that and allowed to gain further insight into what type of access issues may be occurring. Question 2 was also qualitative and stated, what could Colorado Access improve service on for its members, with the intent of having an actionable question where we could develop potential interventions based on member responses. Question 3 highlighted what referral options were offered by our staff during the call. So we didn't ask members this, we just recorded what resources we gave them during the call. And so all of these questions are unique because we are getting information that isn't accessible within the standard claims data that we receive. So survey demographics. For this survey, we had 508 survey responses collected within 9 weeks. 61% of respondents were female and 39% were male. And this ratio is very typical of past surveys we've done, generally way more toward female responses. For race and ethnicity, the majority were white at 37%, followed closely by Hispanic and Latino. And generally, these demographics are similar to the Colorado Access overall member demographics, where white is our largest category, but Hispanic Latino is a close second. So more demographics, survey makeup by age. The 20 to 45 age group was the highest, followed by the 0 to 9 and 10 to 19 age groups. And this makes sense with a good proportion of those survey respondents representing CHIP or Child Health Plan Plus, line of business. And so the age groups of 45 and up were less represented. And then diving into that line of business survey makeup, our survey data showed that Ray 3 was the highest representation, which also represents our Colorado Access member demographics, as over half of our membership is Ray 3 or Region 3. CHIP had the second highest responded rate at 33%. And it's interesting because only 5% of our membership is CHIP. However, we discussed this internally and believe that parents are much more likely to be calling in for their children with questions. And so this likely contributes to that overrepresentation. Ray 5 was pretty similar to our overall member population. And then Denver Health was our lowest at 5%, even though our population is at 17%. Diving into that a little bit more, Colorado Access manages the behavioral health capitated benefit for Denver Health. And so with this partnership, we manage the behavioral health claims and resources for Denver Health, but Denver Health manages those physical health claims and resources for their members. And so it's likely that the majority of Denver Health members are calling their customer service teams for physical health needs. So let's dive into the data. Question 1 results showed that 20% of members had trouble scheduling an appointment in the past 6 months. And we dug into this a bit further and asked if they had trouble scheduling, why? And we did a qualitative thematic analysis to categorize the top member responses for why they had trouble scheduling, which are shown in this chart. 38% had barriers to appointment access and scheduling. So this just includes long waiting times to get an appointment or provider having absolutely no availability to schedule. 22% had trouble finding a provider or service that accepted Health First Colorado. So we had members trying to find dermatologists, therapists, or just members who needed specific operations, and they just had difficulty finding people who accepted Medicaid. 15% had difficulties with the Health First Colorado plan or system. So the majority of these were members who were unsure if their coverage was active or if their plan information was incorrect. 11% mentioned issues with network adequacy, so meaning there were limited provider options that accepted Medicaid in their preferred area, especially for specialty clinics. So another example is that the provider's panel was closed, so they were no longer accepting new Medicaid patients, but the member had no way of knowing that unless they called the clinic, and then that just leads to a lot of frustration where you're calling practices and just being told they can't see you because they're at their limit of Medicaid patients. 8% experienced medical office barriers such as staff shortages or technology issues, and then 4% quality of care was the least reported. We did explore this a bit further and wanted to investigate what drives these access issues. So we did ran a logistic regression model to look at associations between access to care issues and other demographic factors. And so we found that there was an association between line of business and access issues. So we did blind this data because we're still looking into it further. But line of business 2 was 7.6 more times more likely to report access issues, followed by line of business 3 and 4. We also looked into race and ethnicity and did not see any associations there with access issues. And we also did not see associations based on the distance between a member and their primary care provider. All right, question 2 results. So this was a qualitative question again that asked, what could Colorado Access improve service on for its members? 49% of members did not have feedback for improvement or just stated that everything was going well. But for the 51% that did give us responses, we again did a thematic analysis to categorize member feedback. So the first suggestion was better explanation of Health First Colorado coverage, benefits, providers they can see, and the Ray and Chip nuances. The second suggestion was needing more providers to accept Health First Colorado. Third was knowing who to call for help. Many members have questions about their coverage. They have billing concerns, needing help switching PCPs, getting community resources, but it can just be really difficult to know who to call. And so sometimes Colorado Access can help, and sometimes you have to call Health First Colorado, and it can just get really confusing and frustrating for our members. Suggestions 4, 5, and 6 are related. So when members mention wanting more provider options available in their area and learning how to identify these options. Suggestion 7, improved communication when a member's coverage status or rate changes. So things aren't often communicated in the best way from health plans to members, and it can really impact them. An example we received in the survey was a member was about to give birth and her coverage changed right before, and then she wasn't able to give birth with her preferred OBGYN, and it turned into a less favorable experience. 8 is improved functionality of the Colorado Peak app or website, and that's the online portal that members use to manage their Health First Colorado benefits. And then lastly, 9, improving the Colorado Access Find a Provider tool. So most insurance plans have a Find a Doctor tool on their website. However, these can be really difficult to use. They can not be patient friendly. Sometimes the results are misleading. A member can have trouble finding a specific provider they're looking for, or the provider they found said they're accepting Medicaid patients and they call and they aren't, or they just can't get any search results to hit at all because the system isn't intuitive to use. And so these frustrations can cause members to really start losing that trust and hope to find what they need. And so we got a lot of great information here. A lot of what was collected within the survey was what our customer service and care management teams hear anecdotally, but never had a platform to collect that hard, solid data to prove the problems that they were hearing on a daily basis. And this data gave both our members and internal teams a voice and allowed us to escalate this to leadership and give us the opportunity to discuss more organizational interventions that would improve the member experience. And so we'll go into that a little bit on the next slides. Just a quick update on the customer referrals. So as mentioned earlier, our customer service team refer members to a variety of places and services when helping them navigate questions or issues. And tracking this information helps us better understand our member needs. So our team recorded 249 referrals that were given during calls. So 50% were giving outside resources for help. The top referral types were grievances from members. This was just meaning a member was reporting a problem or complaint that our teams follow up on. This was followed by the customer service team helping them find a provider, and then lastly, helping them contact Health First Colorado directly. And then we also recorded what type of provider they needed help finding. And the majority were primary care providers, and then followed by behavioral health providers, and then specialty care providers. All right, so improvement initiatives. What did we do after we got all this data? So after getting the results from the survey and then hearing that validation of anecdotal feedback from our member-facing teams, we decided to take action on some of these things that we could do internally. So we made member-facing website improvements, especially focusing on answering that question, who do we call for what? As even internally working within this field, that can be really confusing. And so we built a whole new interactive web page that answered these questions for members. And it was great because our internal teams use that now too. And we're also in the process of updating our Find a Provider search tool to make that more member-friendly as well. We worked on a new system to enhance our network adequacy. So as described earlier, sometimes members or our internal teams can come across incorrect data within the Colorado Access system or in real time when talking to a practice. And so we created a form where members, providers, and internal staff can report this real-time error so that our internal backend teams can investigate this. And so some examples of this could include incorrect provider addresses, phone numbers, a provider's no longer in business, providers not accepting patients when they should be. And so it's been great to really start taking action in the moment and trying to make our network data as accurate as possible. And then also helping us learn more about potential opportunities to recruit providers in specific areas, depending on the data that we're seeing. And we also monitor member access to care through a variety of programs. Our access to care monitoring program trains providers on community access standards, assesses their ability to offer appointments in a timely manner, and will work with a practice on individual level on the quality improvement strategies if needed. So I thank you all for inviting us to present today. That's the end of our slides. And if you have any questions, please feel free to ask now or email us as well.
Thanks, Sarah and Lauren. What questions do folks have?
Hi. I was just waiting to give others an opportunity. I feel kind of biased because I love Sarah and Lauren and your presentation, and they're great colleagues to work with at Colorado Access. So it was great to see the work that you do in this format. Thank you for sharing. A question, I mean, I had a few throughout the presentations, and one of the questions that I thought about was intersectionality, just that theme. And so just kind of not just intersectionality around the content and the topics of the, the survey items, but also how it intersects with, say, if we're looking at Colorado Access, internal, or structures, other kind of departments that holistically approaches this care, and not just care, but, soliciting feedback. There are several avenues and channels that we use as an institution to solicit and gain membership feedback. And it sounds like a lot of the great work that you're doing over sex, and not just within internally. I think this can also be overlaid with external efforts, like with the CDPHE, HCPUF, other state data, or third-party data. But have you, in what spaces do you see yourself in, in when you're thinking about process improvement do you see yourself being in as, you continue to enhance your data? Because like you said, we don't want to bombard members and folks with all these questions from all these different sources. So how can we leverage what already exists to supplement what you have, and then, kind of create a more comprehensive narrative, so that's not just this is the rate for COPD or their experiences, but why? And a lot of these fall along equity lines, racial lines, things like that. But I think, we can always blow up the picture, and we can find intersections where we can exist to elevate the narrative. So I know that's a broad question, but if either of you could speak to that, that'd be great.
Yeah, I can start, and then Sarah, you can fill in. Thank you, Aveen. We really appreciate your partnership in general too. But I think I've been thinking about this a lot, and I think we have one survey process. You won't know we have this good partnership built with customer service where we can ask, we can include other teams, like, what do you all know? What do you all want to know about? What are you curious about? Is there something in the claims data that we want to investigate, in 2024? I think that Sarah and I have talked a lot about, we have a short survey, right? Which is pretty unique. So we don't have a ton of room there, but we find that members are, prefer shorter surveys. So we try to keep one survey question as just, what is your experience like? How can it be improved? And then the following survey questions, we want to keep as exploratory, and they can be different every time. So this past survey, we asked about access. The next survey, we are investigating a different way to ask about race, ethnic, and cultural identity. So we're exploring that topic next. And I think just this is a really good avenue for other teams to come in and utilize this, already existing structure. Sarah, do you have anything to add?
Yeah, no, I really appreciate this question. And I think just to go into potentially elevating this survey in the future, and kind of our dreams with this survey would be to move more into the community space and kind of add more survey feedback from different methods. And I know you know this, Levine, but we're hiring a new member experience officer within the organization, and we're really excited to partner with them and explore this opportunity of perhaps doing this survey in some other community spaces when we're talking to members directly, instead of them calling over the phone. We've talked with a few practices who are interested in potentially having this survey. They could do it within their practice for our members. And so we were trying to think of some really unique and creative methods to potentially expand this in the future. And we're really excited to potentially do that.
And it's really exciting. Thank you for those responses. And again, not to make this COA hour, but I do really appreciate what you both said. Lauren, to your point about kind of that flexibility with that one survey item. I know that as somebody who works in a different arm than you all in the company, I questions around how do we make our data more equitable, less racist, right? More reflective of the populations that we are serving, because we know that is how disparities through data perpetuate, is if they're not representing the data, then they're essentially not targeted in the programming. And so I remember when that was a heavy conversation, you all took that and ran with it and are making that another survey item. So I'm really proud, again, of the work that you're doing and being a partner in it.
Good question. That's really interesting. There is a question in the chat from Kat. Kat, do you want to get off mute, or are you okay if I read the question? Okay.
Sorry, I can read it.
Yeah, go ahead.
I was struggling to find the mute button. Just wondering what the process of recruiting and or encouraging new providers to accept Health First, because that seems to be kind of a theme that comes up as a challenge for folks. So I don't know if you're part of that process, but if you could speak to that a little.
So I could start with that. We are not part of the process with recruiting. However, I know that we did hire a new recruitment manager in the last 6 months. Everyone in the organization was very excited about this. And that's something that she's just really excited about, and thinking about new ideas on how to recruit new providers, learn more about where we need to recruit new providers? Where are we missing providers that we could, potentially recruit more? I know we offer a lot of different incentives too, to just encourage providers to want to partner with us. And so, Lauren, anything else speaking to that?
I don't think so. I mean, I think we hear a lot about what members want. So maybe our role in this process is just giving that information to the teams that are responsible for that.
All right, if I have time for one more question, does anyone have a question?
I'll ask one more. If no one. Where do you see this work in 10 years?
I like this question. Let me take a second to think about it. I mean, this work in 10 years, so understanding community voice is always important, right? And so I think I see this work in 10 years being bigger and more immersed in communities. So maybe at community events, we'll be collecting member voice, or maybe our member advisory council will be really big and we'll be able to connect to more members that way. I think I'm just dreaming bigger. What would you add, Sarah?
That's exactly what I was thinking too. I would just, we hit 500 surveys, and our customer service and care management teams do so much, right? So we can't burden them with this for too long. They do it for about 2 months, and then we get this great information, but a small amount of members. And my dream would be to expand it to as many members as we could touch, and especially the members who don't have a voice or have a really hard time, whether doing translation with the survey, just opening that up so much more and getting a lot more information would be wonderful.
Yeah, and information from members who don't often call into customer service. Like the refugee population is a pretty difficult population to survey, but their voice still matters. So expanding it in that way too, make it more equitable.
I love those dreams and ideas. I hope that they happen. I know it's like a long work in progress. And like you mentioned, with the speed of trust, right? And inclusion, and really building those community relationships and utilizing like what assets and events and Go Where Community is. I love that. So, well, thank you everyone for attending this session and engaging in the Q&A. Couple announcements. So the slides and the handouts, the speakers are provided. They're available on the Schedule app. You'll receive a conference evaluation form via email when the conference is over. Please fill that out, even if you only attended just this session or even a small portion. It's really helpful for our planning committee as we think about next year. And if you fill out the survey, there's a raffle for everyone who completes it within 2 weeks, and you could win one of 2 $50 gift cards. I don't know what the gift cards are for, but you could win one. That wraps up today's sessions. And tomorrow, the time frame is 9 to 12. The Emerging Leader Showcase session begins at 9. There's 3 presentations from Rising Stars in Public Health. And we hope to see you there. And there's a couple of breakout sessions that follow that. So the full schedule's on the Schedule conference website. Nice to see you all. Thank you so much, and have a good afternoon.
Thanks, everyone.